So, self-assessment for this chapter, the patient with elated or irritable mood. Multiple choice questions. A reception staff asked the general practitioner to see a 29-year-old man with a history of bipolar affective disorder who has arrived 2 hours late for his appointment. He is speaking very quickly and the words don't make sense. What's the most likely cause for his presentation? A. Manic episode. B. Hypomanic episode. C. Depressive episode. D. Cyclothymia. E. Schizophrenia. Okay. The patient, so with acceleration in speech and the probable thought disorder, and because of significant functional impairment, his symptoms suggest manic episode. So the answer is A, manic episode. Okay, so that's it. Another question. A 55-year-old man has had several admissions to hospital with elated episodes when he believes he is Jesus Christ, but has never been depressed. What is the diagnosis? A. Recurrent hypomania. B. Bipolar affective disorder. C. Schizoaffective disorder. C. Cyclothymia. E. Recurrent mania. Here we are talking about bipolar affective disorder. An episode of depression is not necessary to meet criteria for bipolar affective disorder. Recurrent mania and hypomania are not diagnoses. No first-rank symptoms are mentioned, of course, if you are talking about DSM-10. So, and we have no prominent psychotic symptoms that would rule out schizoaffective disorder. Cyclothymia is excluded by the presence of psychotic symptoms, of course. So we are talking about bipolar affective disorder. A 25-year-old farmer is brought to accident and emergency by the police after he tried to steal a tractor. He is agitated but shows no remorse, stating loudly that it rightfully belongs to him as he is the king of tractors. He has no past psychiatric history, past medical history, or previous criminal offenses. Which investigation would be most important diagnostically? A. CT scan. B. EEG. C. Full blood count. D. Urine drug screen. E. Thyroid function. Okay, the answer is D. Urine drug screen. Okay, so question number 4. A 24-year-old unemployed woman presents with to her general practitioner asking to be treated for bipolar disorder. She has looked it up on the internet and thinks it may explain why she is always losing her temper with people. Her mood swings frequently, sometimes several times in a day. She often does things she later regrets and has never managed to maintain a long-term relationship or job. She has had these mood swings from when she was a little girl. What is the most likely diagnosis? A. Bipolar affective disorder. B. Dysthymia. C. Cyclothymia. D. Personality disorder. E. Substance use. We are talking about personality disorder, of course. This woman describes a persistent pattern of maladaptive behavior present since childhood, associated with social and occupational dysfunction. This is most likely to be a personality disorder. With prominent impulsivity, it would be important to get a collateral history before making a definite diagnosis, of course. The mood swings are faster than would occur within bipolar affective disorder, and she has never had a period of euthymia required for the diagnosis of mood disorder. The symptoms cause marked functional impairment, so that would exclude cyclothymia. Dysthymia is prolonged low mood, not mood swings. So it's not. Although substance use can cause and worsen emotional lability, it should not have onset in childhood, of course. So let's go to the extended part of the questions. So, about differential diagnosis of elevated or irritable mood. We have these differentials: hypomanic episode, manic episode without psychotic features, manic episode with psychotic features, mixed affective episode, bipolar affective disorder, cyclothymia, schizophrenia, schizoaffective disorder, elevated or irritable mood secondary to general medical condition, elevated or irritable mood secondary to psychoactive substance use, delirium, or dementia. So, for each of the following patients, select one most likely diagnosis from the list above. A 40-year-old lawyer attends his general practitioner asking for a medication to reduce his sex drive because his wife is complaining. He is smartly dressed in a new suit and says he feels on top of the world. He has been finding it hard to stay focused at work, but so far no one has commented. Fortunately, he is able to stay up late catching up on work without feeling tired the next day. He denies any drug or alcohol use. Here we are talking about hypomanic episode because this man describes an elated mood with a decreased need for sleep, poor concentration, and increased energy, increased recent expenditure, and increased libido actually. It is interfering with his social and occupational function, but these activities are not completely disturbed. We are not given information on past mood abnormalities, so the diagnosis of bipolar affective disorder is not appropriate. So here we are talking about hypomanic episode. Another case: a 22-year-old trainee electrician is brought to accident and emergency by the police after he was found breaking into an electronics shop. He states he needed the parts for a new jetpack he is designing. He plans to start a new business with it, which will revolutionize trans, trans, transat, transatlantic flight. He has resigned from his apprenticeship. His apprentice. Apprenticeship. Okay. In order to spend more time on this venture, he is irritable with the male police officer, but flirtatious towards the female police officer. He denies drug or alcohol use. Okay, this patient has manic episode with psychotic features, of course. This man has irritable mood, sexual disinhibition, and grandiose delusions, which have led him to commit that offense and quit his career. Schizophrenia is made less likely by the presence of mood symptoms and disinhibition. It would be important to check a urine drug screen to exclude mania secondary to psychoactive substance use. We are not given information on past mood abnormalities, so the diagnosis of bipolar affective disorder is not appropriate here. So, next here we have this. Again, we are talking about diagnoses according to ICD-10. That's different from differ from ICD-11 and DSM-5. A 37-year-old man with a history of bipolar disorder was admitted to a psychiatric ward 1 day ago. The nurses tell you he has been very elated and disinhibited so far today. When you interview him, he seems low and tearful. But as the interview progresses, he gets very irritable and starts to speak too quickly for you to ask him any more questions. The patient here has mixed affective episode because The man shows rapid change between an elated and low and even irritable mood within 24 hours. That's the definition of mixed affective episode in ICD-10. Another case, a 36-year-old secretary attends her GP because she is feeling unusually irritable at work. Sometimes she loves her job and sometimes she hates it, but forces herself to attend. Right now, she is also feeling irritable with her family and neighbor. She has noticed her mood has seemed to cycle since her late teens, but it has never stopped her doing anything. Mostly, we are talking about cyclothymia, I would say, or even something like, personality disorder. But this woman describes alternating periods of mild elation and mild depression since early adulthood, which do not impact on her functioning. So we are talking about cyclothymia mostly. Cyclothymia. The last case here, a 28-year-old doctor suffers from recurrent depressive disorder. He has recently started a stressful new job and his flatmates are worried because he doesn't seem to be eating or sleeping well, despite seeming quite cheerful. He paces the flat at night talking about new operative techniques he is designing. His consultant sent him home from work because he refused to scrub for theater, stating, "I'm pristine already." Okay. So maybe the patient here has current episode of mania with psychotic features, and he has history of depression. So we are talking about bipolar affective disorder. We can diagnose the patient with that. Okay, let's talk about another question. Elevated or irritable mood secondary to general medical condition or psychoactive substance use. Here we have the causes. For example, Huntington's disease, multiple sclerosis, Parkinson's disease, cerebral tumor, Cushing disease, hypothyroidism, hyperthyroidism, anabolic steroids, corticosteroids, L-DOPA, cocaine, and amphetamine. Okay. So for each of the following patients, select one most likely cause from the options above. The first case here, a 66-year-old man with a shuffling gait and reduced facial expression has recently had a medication increase. Now he is elated, spends all his time playing online poker, and asked his wife where all the monkeys in the kitchen had come from. So this man probably has Parkinson's disease and is likely to be treated with dopaminergic agents such as L-DOPA. So that would be the answer, L-DOPA, a precursor to dopamine. So excess dopamine is associated with euphoria, psychosis, and a reduction in impulse control. Okay. So that would be the answer. Another case, a 22-year-old student is brought to accident and emergency by his friends from a party because he tried to fly off the roof. He is adamant he is Superman. He admits to having swallowed a pill earlier. On examination, he is restless with dilated pupils. So, okay. So we have, acute psychosis, dilated pupils, and so on. So mostly we are talking about amphetamine here. Why is that? Because amphetamine intoxication can be associated with an acute psychosis. It is asymptomatic. Its symptoms are obvious here,
We are talking about stimulant, of course. So that's why we have these symptoms of agitation. Some kind of activity, hyperactivity, and the dilated pupils as a result of the sympathomimetic action of amphetamines. The answer may be cocaine also, but usually cocaine is smoked or snorted, not taken as a pill. Okay. Another question. A 28-year-old bodybuilder has recently become convinced he will win the next world championship. He is irritable with his girlfriend whenever she queries this. He is also hypersexual and forgetful and has been uh, reprimanded at work. Uh, so, bodybuilder is something here by this question. So, that's why we answer this question with anabolic steroids. These are commonly used by bodybuilders to increase muscle bulk, but can be associated with changes in mood, arousal, and cognition, as in this case. Another case, a 62-year-old woman is an inpatient on an acute medical ward following severe asthma exacerbation. The nurses notice she seems irritable and suspicious and keeps asking for single room as befits someone of my status. Her daughter says this is a complete change from normal. So, here corticosteroids may cause these things because high dose of corticosteroids are often prescribed for severe acute asthma. That's why we suspect that. Mood changes and psychosis are common psychiatric complications of steroid use, as in this case. Another case, a 45-year-old woman presents to A&E with palpitation. When not seen immediately, she becomes extremely irritated and starts pacing in the waiting room. On examination, she has a tremor, pupils are normal, and ECG shows sinus tachycardia. She shouts at the ECG technician for not being gentle enough when she removes the electrodes. Okay, so we may answer this question with hyperthyroidism because that's suggested by tremors, tachycardia, and irritability. And of course, substance use is an important differential diagnosis here, but with normal pupils and no other signs, that would make stimulants less likely, which is the most differential from substances, of course. Okay, let's talk about mental state examination in elevated or irritable mood. We have pressured speech, flight of ideas, tangential thinking, poor concentration, psychomotor retardation, psychomotor agitation, hyperacusis, visual hyperesthesia, auditory hallucination, and visual hallucination. So, lead in for each of the following patients. Select one clinical feature described from the list of options above. Again, pressured speech, flight of ideas, tangential thinking, poor concentration, psychomotor retardation, psychomotor agitation, hyperacusis, visual hyperesthesia, auditory hallucination, and visual hallucinations. So the first case, there are no natural breaks in the conversation and it is impossible to interrupt the patient without speaking over them. This is pressured speech. Pressured speech. Okay, the second, the patient comments she has never seen a blue as the nurse's uniform before. Here we are talking about visual hyperesthesia, which is an increase in intensity of perception here. Visual hyperesthesia. 3. The patient speaks normally and initially starts to answer a question but quickly diverts onto related but unimportant topics. This is tangential thinking. Okay. I would say flight of ideas actually. answer, but quickly divert into to related but unimportant topics. So tangentiality would answer it. Okay. The the patient speaks rapidly and initially starts to answer a question, but very rapidly diverts into lots of other topics. It is very confusing to listen to, but in retrospect, there are links between the topics. Some of the links were rhyming words. Here we are talking about flight of ideas, of course. The fifth case, the patient is trying to complete serial 7s but keeps being distracted by the noise of hoovering. Distractibility or poor concentration. 6. The patient comments there is a beautiful blue bird in the corner of the room, but no one else can see anything there. Here we are talking about visual hallucination, of course. So that's it.